Good morning, everyone, and welcome. I'm Leanne Griffin, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Infectious Disease Control for Persons Who Inject Drugs. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, I'm the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. You may use the Q&A panel to send any questions you have as you think of them throughout today's presentation, and the presenter will answer questions at the end of today's presentation, or possibly at the break, depending on our schedule for today. Our audio is being broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and I've also posted these options in the chat panel too. If you continue to experience a loss of audio through your computer speakers, try rejoining the webinar and call in using the telephone I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 5 business days. And the website address is www.fada.org. Also, a PDF version of this PowerPoint presentation will be emailed to participants also within 5 business days. Approximately 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and also for persons credentialed through the Florida Certification Board. At the event's conclusion, the web browser will direct participants to an evaluation form on the FADA website. If you would like to receive continuing education credits or a certificate of attendance for this event, you must complete the evaluation. Be sure to include any Florida license number, if applicable, for reporting to CE Broker, along with the prefix for your license number. Your certificate of attendance will be delivered to your email address within 5 business days. Do note, please, that WebEx monitors arrival and departure of attendees and provides me with a report upon completion of the event. This attendance log and the evaluation forms are used to validate the provision of contact hours or the certificates of attendance. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial credit. At the conclusion of this training today, participants will increase knowledge of trends and the relationship between the opioid and infectious disease epidemics, and Dr. Cook's going to talk to us about that. Participants will also learn about engagement strategies and innovative approaches to opioid and infectious disease prevention, and also will understand evidence-based strategies for addressing the spread of infectious disease among persons who inject drugs, and Jesse Bennett's going to help us on that section. And I'd like to introduce our presenters now for today's webinar. Robert L. Cook, MD, MPH, is Professor of Epidemiology and Medicine and the Director of the Southern HIV Alcohol Research Consortium at the University of Florida in Gainesville. He received his MD and MPH degrees from the University of North Carolina, Chapel Hill, and then completed residency training in internal medicine at the University of Virginia. He has been at the University of Florida since 2006, where he is leading several research projects related to alcohol, other drug use, and HIV infection in Florida. Jesse Bennett, BSW, is the Harm Reduction Volunteer Organizer Consultant for the North Carolina Harm Reduction Coalition. A former drug user and a formerly incarcerated person, Mr. Bennett is currently the statewide volunteer coordinator in North Carolina, and as such, he participates in and advocates for harm reduction efforts in the community. These efforts include, but are not limited to, access to clean syringes, access to naloxone, and safe sex practices. Jesse plans to pursue a master's in social work with a focus on harm reduction therapy, and it's my pleasure to introduce both Dr. Cook and Jesse Bennett and have them join us today. And at this time, Dr. Cook, if you're ready, I'm going to move over to your presentation.
I'm ready.
And I'm going to pass control of the presentation over to you. You should be getting that in just a moment, and then we're ready to go. And when you're ready, Dr. Cook, you can use your mouse and click inside of the PowerPoint pane. And your page up and page down key should help you navigate.
For some reason, it stopped working. I haven't.
Do you see the presentation in front of you?
I do.
Okay, and did you click inside of it with your mouse?
Okay, got it. Good morning, everybody. I hope this works. Let's see. Is this right?
I did see it move.
Okay. So good morning, everybody. I hope you can hear me. This is Bob Cook. I really want to thank the program organizers for inviting me to give the talk. And we already discussed these 3 learning objectives. I'm going to talk to you about the epidemiology of infectious diseases linked to the opioid epidemic. And the points that I'm going to review, I'm first going to describe trends in opioid-related deaths in Florida, sort of what is the epidemiology of that. And then I'm going to describe some basic information about HIV and HCV infections, that's hepatitis C virus. And I will describe trends in time in opioid use, HIV, and HCV, and how these vary by geography, gender, and age. And I will discuss several specific interventions that can help to reduce opioid-related infectious diseases. And I know that my colleague, Mr. Bennett, is going to go over some of these again in more detail. I'm first going to start with 2 slides that just give some random facts that sort of highlight different aspects of what we're going to talk about. So in 2015, there was an outbreak in rural Indiana linked to persons with injection drug use, needle sharing, and there were 170 people infected with HIV in this epidemic, and it really caused an alarm nationally because it was in a rural area where we wouldn't really expect HIV to be spreading. Another point, since 2000, the rate of deaths from drug overdoses involving opioid pain relievers and heroin has increased 200%, and I'll show you some more specific data related to this in a moment. 56% of Black transgender women had positive HIV test results, compared to 17% of white or 16% of Hispanic transgender women. Now, first of all, transgender women at anybody at 15 or 16% is a huge incidence of HIV. And while there aren't huge numbers of transgender, we do believe that at least 2 or 3% of the people with HIV in Florida right now are transgendered, and they are having a lot of issues related to stigma and HIV, and you can see that there are racial disparities as well. Almost 45% of estimated new HIV diagnoses in the United States were among African Americans, who only comprise 12% of the U.S. population. I think I have a slide in this later, but again, what you're going to see in terms of HIV infection, it's one of the highest racial disparities you're going to see in almost any disease or condition in the United States. There's a lot of reasons for it. And then more than 25% of the 45% were women. And the point there is that there's also racial disparities in women. Just racial disparities across both groups. And then 7 in 10 new HIV diagnoses among Hispanics occur in gay and bisexual men. This is actually true for all new HIV infections in the United States, that really we are seeing a lot of the epidemic emerging in gay and bisexual men, but we still do have HIV infection being spread through injection drug use. And again, I'll show you some data related to that later in the presentation. The first 5 or 6 slides are really going to be just to talk about some of the epidemiology of opioid use, and especially in Florida. What this slide shows is that compared to 2005, over the past 10 years or so, up to 2015, the percent of new persons with infectious people that inject drugs by race suggests that fewer blacks and more whites are starting to inject drugs. And you can see this top box is the white proportion of people that are starting to inject drugs. And so when we look at opioid injection drug use, at least in terms of epidemiology, we are seeing a shift towards white persons and away from minorities, which is in some ways counter to what you see in the overall HIV epidemic, but certainly among those that are getting infected by injection drugs, more and more white persons. Now, this is an annual report of drugs identified in deceased persons by the Florida Medical Examiner. So if you want to know, in Florida, what drugs were identified in people that were reported to the medical examiner, and that means they often had a suspicious or unexpected death. We can see what some of the trends are, and this recently was published. This report examined data from 27,383 deaths that were examined by medical examiners in Florida, and actually did include data from 2016 versus 2015. And what you see in just comparing just the last 2 years, the total drug-reported deaths increased by 22%. Opioid-related deaths in Florida increased 35%. Prescription drugs were found more often than illicit drugs, meaning that prescription things like benzodiazepines and opioids were more commonly associated with things like methamphetamine or marijuana. Heroin deaths increased by 30%, and fentanyl deaths increased by 97%. And we also had increased deaths related to morphine and methadone. So these last groups of deaths are all related to opioids, and you're going to see in a minute that the synthetic opioids, or the fentanyl-related opioids, are actually really what seems to be causing more deaths. This is the number of deaths. That was the most common cause of death in Florida in 2016. So cocaine overall was associated with the most common causes of death. After that, benzodiazepines, things like Valium and Xanax, Ativan. Fentanyl then comes in next at 1390, morphine, fentanyl analogs, and so these are also very potent opioids that are injected. Heroin is still usually injected, although it can be snorted or used otherwise. And then alcohol-related deaths, interesting, were lower. And then oxycodone, which is an oral opioid, and methadone, which is also oral opioid. So you see that the injection opioids are really responsible for overall the majority of drug-related deaths in Florida. And benzodiazepines and cocaine are certainly common as well. And a lot of these people that died had multiple drugs in their system. This graph is hard to read. I'll tell you that along this axis on the side is the number of occurrences. So higher is more. And the red, blue, and the green bars represent data from 2014, 15, and 16. And so you can see that in most of these classes, the number of occurrences of deaths related to drugs increased over the last 2 years in Florida. This is alcohol, alprazolam, which is a benzodiazepine, cocaine. You can see we really had a spike last year. Heroin, there's been a consistent spike. Fentanyl, morphine over here. So what you see is at least keep in mind, these are only deaths reported to the medical examiners, but of those they investigated, we're seeing more and more related to these opioids. And this slide shows a historical overview of the deaths caused by hydrocodone, oxycodone, and methadone. So these are our oral pain meds, and this is Florida data from 2007 to 2016. The red line is oxycodone, so you can see that right around 2010, we were really having an explosion of oxycodone-related deaths. But at that point, a lot of interventions came in from the prescription drug monitoring program or other kill mill shutdowns and things like that. You can see that the number of oxycodone-related deaths went way down, although we're seeing a slight rebound. Hard to tell the trend here. And then in terms of methadone deaths, they've gone down, and hydrocodone has been hardly any. This is just a geographic distribution of fentanyl deaths by county, and this is occurrences. So where there's more people that live there, of course, there's going to be more occurrences. It's not a rate. But you do see, interesting, that Palm Beach County really had the highest occurrences of any other county. And then this rural county, Clay County, which is close to where I live in Gainesville, has cities like Stark and all that, and then Duval County, where Jacksonville has had the very highest number of fentanyl-related deaths. So I usually think of more injection drug use going on in South Florida, so it's interesting that there's been more fentanyl-related deaths in Jacksonville. And you see that there's some in some of the different rural areas as well. This is you can see how fentanyl has just emerged as an emerging drug of injection drug use-related deaths. And so you can see 1,600 people, and that's almost more people than are dying of HIV infection in Florida. So, you know, this is really a serious epidemic independent of its infectious disease issues. And then heroin deaths by county were fewer than the fentanyl deaths. You can see that also Palm Beach County had some of the higher rates than one of the Panhandle counties, but otherwise relatively geographically distributed in both rural areas and urban areas in Florida. And this is just in terms of who is dying. So if you look at age and fentanyl-caused deaths, all these are different regions in Florida, and that's not so critical, but if you look at the ages, you can see that most of the deaths are 26 to 50 years old. So a lot of these deaths are occurring in people before age 50, okay? Actually, Sarasota, you can see here, had a big number of fentanyl-related deaths in this particular graph. And then I'm just showing you this just because prescription opioids are still out there, although they're not as responsible for as many deaths, and they're also not as responsible for as much infectious disease transmission. It is interesting to see, now this is rates and not absolute occurrences, so it is kind of divided by the total population. But you can see that in some ways oral prescription opioids are more concentrated in our rural areas of the state, especially up in the north central part of the state. And oral opioids have not been really prescribed quite as much. But again, part of it is because there's just a lot more people here, and these are rates instead of absolute numbers. So keeping in mind that one of the major health issues related to these drugs, injection drugs, is the deaths. For people that aren't dying, there still can be a lot of infectious disease transmission, and the two that we're going to focus on today is human immunodeficiency virus, HIV, and hepatitis C infection, HCV. And again, I'll talk a little bit about this, and I'm going to show you some epidemiology of these infections, especially in Florida. And then, again, I'll touch on a couple of the interventions that people are doing to try to reduce both in disease transmission. And again, Mr. Bennett in the second half is going to go in much more detail about some of these strategies and interventions. So this could be a review for some of you, but just to make sure we're all on the same page, HIV infection is the human immunodeficiency virus. This virus attacks cells in the human immune system. It attacks cells that have the CD4 marker on top of them, and that's a particular type of lymphocyte. It's a helper T cell, and it is what usually tries to kill viruses. And so when the virus kills that cell first, it really beats down the immune system, and without treatment over time, over about 10 years, people will develop AIDS and die. Now, it's a relatively new disease. The first cases of AIDS in the United States were described just in 1981. There are two main risk factors that continue to spread HIV: sexual transmission, that's occurring especially in men who have sex with men, but it also occurs in heterosexual transmission. So the women that are getting infected are the majority of them getting it through heterosexual transmission, and certainly at least some of the men are getting it through heterosexual transmission. But transmission through blood factors also continues to be an issue. So injection drug use is the main way today that HIV is transmitted through blood-related activity. Blood transfusions at one point were responsible for reasons why people with hemophilia, for example, were getting HIV early in the epidemic. But today, our blood banks are doing a very good job of screening the blood supply for this virus as well as hepatitis C, and so very, very few infections are being transmitted through the blood. I'll also say certainly maternal and fetal transmission can happen with HIV, but it's much less common now than it was many years ago. Unfortunately, we have fewer than 100 cases per year that are occurring in Florida, probably fewer than 20, to be honest. It's very uncommon now because of the treatments available to prevent transmission from mother to child. But these are the main risk factors. Just to remind you about the history of HIV, it killed most everybody and was quite devastating disease until about 1996. We got combination antiretroviral therapy, and those medications have continued to improve. And today, I'm happy to say that if people with HIV take the combination antiretroviral therapy, they can suppress their virus to undetectable levels, which is a great strategy to prevent transmission to other people, either through drugs or sex, but also helps people live longer. And so the HIV viral suppression is possible with ART, but there's no cure yet. So in order for people to be suppressed, including injection drug users, they need to take their medicine every day. And in Florida, not everybody does that. HIV viral suppression is associated with improved survival in individuals and reduced transmission of HIV to others, so that's a key public health strategy. And diagnosis and treatment of individuals is a key part of the HIV prevention strategy. And so as we think about preventing HIV transmission in drug users, we need to think about ways to ensure that those drug users who are HIV positive are diagnosed and treated for HIV, and that way that will reduce, that's one strategy to reduce transmission of HIV among people who do inject drugs. There's currently 1.1 million people living with HIV in the United States. There were 37,600 new HIV infections in 2015, which is a 7.5% decrease overall. There was a 7% of these new HIV infections were due to injection drug use. And that's been pretty stable over time. We'll look at it. I'll tell you guys that almost 5,000 of these new HIV infections occurred in Florida, which means that more than 1 in 10 of all new HIV infections in the United States occurred in Florida. And in Florida, again, 5 to 7% of the new infections were due to injection drug use. So while there are declines overall, that's not happening in Florida, and Florida continues to lead the nation in HIV infection new diagnoses. I already said some of this, but again, 4868 newly diagnosed cases. We have about 112,000 people living with HIV in Florida overall. We do have the highest number of new HIV infections in the United States. A combined region of Miami, Dade, Broward, and Palm Beach, that whole region has the highest rate of new HIV infections in the entire United States. And most of these new infections are occurring in younger minority men who have sex with men. But injection drug use does remain an important risk factor. This is a slide. We mentioned the outbreak in rural Indiana related to needle sharing. And you can see this was linked to injection drug use of oxymorphone. And so oxymorphone isn't something that we typically see in most injection drug users. So this was a synthetic drug that somehow got tainted or somehow was associated with this outbreak. This slide, again, is back to HIV data. And the whole point of this slide, which shows the rates of diagnosis of HIV among young adults. And so these are younger people. You can see that in Florida and the entire southeastern United States is some of the highest rates of new infections in the United States. So Florida really does have a particular problem with HIV. And that's a little bit different than the data we'll see on hepatitis C later in the talk. So these slides are courtesy of the Florida Department of Health. You can get these on the web. And the data were updated last summer. I checked and we don't have this year's data yet, but this is what it was in 2015, and I think things are generally pretty similar. What you see is that, we were really having new cases until about 2007. Now, at this point, if you remember, the history of HIV is when antiretroviral therapy became used, and people on medication, taking medication does reduce transmission to other people. So initially, we saw these declines, but over the past 2 or 3 years, there's been a slight increase each year in Florida. This shows the case rates by county of residence diagnosed in 2015. So these are new infections. They're not all infections. And these are rates, meaning that's the number of infections divided by the population. So we still do see, though, that the highest rates occurred in some of our urban areas. This is urban areas representing Miami and Fort Lauderdale. This is representing sort of the Orange County, Orlando area, and Sanford, which is Seminole County, Duval County, which is Jacksonville, and over here in the Panhandle, I believe this is Gadsden County, where there is a federal prison, but Gadsden County might be one of these others. I apologize to those of you who live there for, but this is probably Gadsden, and could be related to the prison, might not be, but you can think about that as you think about the interaction of drugs and HIV rates. This is adult female HIV infection cases by mode of exposure and year of diagnosis. And so as you can see that for females, there's been, this bottom line is injection drug use, and they have been pretty much stable, whereas heterosexual transmission in females has started to go down. And so our rates in females are generally improving over the last decade, with just a slow, steady trickle of infections in females related to injection drug use. When you look at male HIV infection cases by mode of exposure and year of diagnosis in Florida, the top bar is men who have sex with men, and it looks similar to the overall trends. And you can see that there has been an increase in the last couple of years. A lot of this is sexual transmission among men who have sex with men is related to substance use. There is a lot of substance use. It's just not as related to injection drug use as it used to be. Now, the yellow line is heterosexual transmission in men. You can see gradually decreasing. And again, injection drug use and men who have sex with men, injection drug use, has, again, just a steady trickle of infections, about 50 to 100 per year. Now, this transmission through injection drug use is completely preventable if either the person that has HIV is suppressed, or the needles are clean, or the participant who is not yet infected is doing something to prevent HIV infection, such as taking medication called PrEP, which I think will come up in this talk as well. I mentioned the racial disparities. This shows adult HIV infection case rates by sex and race ethnicity in 2015 in Florida. And you can see, again, the majority of the cases, this is the rate, so it's not the number, but the rate of cases you can see in men is higher than the rate in females, which we know, but the rate in blacks is the highest, Hispanics is second, and whites is third. And then in females, again, black females have a much higher rate of infection. Some of this is attributed for women, well, there are a lot of explanations for this racial disparity, and again, some of it does have to do with criminal justice system and the fact that more black men are in prison and women have fewer choices of sexual partners or partners to engage in a relationship with is one potential explanation, and that can also be related to some of the drug use issues and potential racial disparities related to jail. Now here, adult HIV infection cases for males and females by mode of exposure, you can see the injection drug use is kind of the dark blue color. So 10% of the cases in females are due to injection drug use. That's about 200 cases per year overall, and 3% of the men injection drug use overall, and 2% men who have sex with men and injection drug use. So 5% of this, and so that's about 150 cases overall. So in Florida last year, we had about 350 total cases of newly diagnosed infections related to injection drug use. Now I'm going to talk briefly about hepatitis C. There are several hepatitis viruses. A, B, and C are the most common ones we see in the United States. They're different viruses, but they have in common that they affect the liver. Hepatitis A is usually acquired by eating contaminated food. Hepatitis B, we don't see as much in the United States because we have a vaccine, but hepatitis B is spread through sex and drugs, just like HIV is. Hepatitis C is almost exclusively transmitted through injection drug use. It is a virus that affects the liver. Transmission via blood transfusion in the past and injection drug use today. There have been a few cases of hep C through sexual transmission, but most of it is through injection drug use today in today's society. Hepatitis C infection can lead to cirrhosis and liver failure over time, and there are worse outcomes in persons co-infected with HIV and HCV. And we do see in Florida that about 20% of people with HIV also have a HCV co-infection, although that number is declining slowly over time. This is a graphic that just explains the proportion of people with hep C that will have problems. So it says out of 100 people infected with hepatitis C, 75 to 85 people will develop chronic hepatitis C if left untreated. Chronic hepatitis C means they have virus always in their blood, and that virus is causing a chronic inflammation and other types of side effects. Over time, 10 years or so, 60 to 70 people, if untreated, will develop chronic liver disease. 5 to 20 people will develop cirrhosis, and it does take a while, 20 to 30 years, and 1 to 5 people out of 100 will die from cirrhosis or liver cancer for everyone infected with hepatitis C, and that's if it's left untreated. But today we are having much better treatments that are available and again, working on finding ways to get those people treated. HCV can be cured. This is a slide I took off the Veterans website. The VA has invested a lot of money in curing hepatitis C. Again, part of it is getting people diagnosed in the first place, and a lot of people in the Veterans Administration were affected through blood transfusions back in the 40s and 50s. But certainly there are a lot of injection drug users who use the VA healthcare system, and a lot of problems with injection drug use in our military veterans. And so it is nice that the VA is working to cure hep C. And I'm not going to get into the treatments today, but they are available. But one of the controversies of treatment for hep C is its cost. It can be very expensive, and maybe I will mention that. I could not, because hepatitis C is not itself reportable condition to the Florida Department of Health. We really don't have numbers of exact cases of hepatitis C. Most of the data I'm going to show you are population-based estimates. Now, these are data from people living with HIV who are co-infected. And the next several slides, just to give you, a glimpse of where in Florida the cases are. So you can see that here again, these are the number of cases. So you would expect more numbers in larger cities. And you can see a big belt in the I-4 corridor here across the middle of the state. And again, our South Florida, which has more population, also has more cases of hepatitis C, and then a few scatterings in some other places. If you look at these, again, are people co-infected with hepatitis C. We know of about 10,000 people, and you can see the racial distribution in males and females. And about 2 out of 3 cases of hepatitis C in Florida is in men. And you can see this is white men are in the yellow, black are in the red, Hispanic are in the green, and other is 2%. So this is kind of equally distributed by race. In females, there are more black with the red color, a higher proportion that have hepatitis C co-infection compared to other races. And again, the majority of this hepatitis C was injection drug transmitted. And if you look at the ages, who's currently living with hepatitis C co-infection, you can see a lot of it is older people. So we have, now again, if you look at overall how many people are living with HIV in Florida, 50% of people with HIV infection in Florida are now over age 50. But you can see of the co-infected with HIV and hepatitis C, 2/3 of those people are over age 50. Okay, so it could be that those people have been infected already for 20 years. But there are new infections occurring in this group as well. And this is HIV/HCV co-infected adult people in the prisons. So usually we don't have data from the prisons, but I think you can see that the numbers are similar and that it's older people that are currently living with HIV. So again, and hepatitis C. So if you think about if people were sharing needles or sharing injection drugs or intervention programs to reduce transmission, those programs do need to consider older persons. When I say older, I'm 53, so I'm in the group too, but you can think about older persons who are living with HIV and hepatitis C co-infections. We need to be sure that we're targeting that population as well. So Florida has a hepatitis prevention action plan. It was developed by a planning group and a hepatitis prevention program. If people in the call are interested in participating in this group, you can look up this report online and probably figure out how you can volunteer and get involved. But they listed some goals. They wanted to raise statewide awareness of viral hepatitis, and so certainly I'm hoping we accomplish that today with some of you all. Develop and distribute educational information, and we need your help with that. Coordinate and collaborate with other programs and entities regarding prevention and intervention efforts. So again, by collaborating with you all who are interested in the alcohol and drug use issues in Florida, that's part of the goal of the Hepatitis Action Plan. Track viral hepatitis case surveillance. I don't know how well they're doing that. At least I couldn't find the data on the web. I just showed you the HIV-related data. Conduct research and evaluation, and reduce viral hepatitis morbidity and mortality. So there's our goals. The action plan says how they would do each of these steps, and I'm not going to go into the specific steps today. Just a few other facts that I found about it in the action plan. There are approximately 321,600 Floridians with chronic hepatitis C. And remember, I told you there's only about 100,000 or 110,000 with HIV infection. So we have 3 times more people with hepatitis C than we have with HIV. There are 22,500 new cases of chronic HCV reported each year. Chronic hepatitis C just means that we diagnose you, we don't know when they were infected. They were infected at some time in the past. And approximately 80% of injection drug users are infected with hepatitis C. That's an interesting fact. I'm not sure. I've seen numbers a little bit less than that in some populations more recently, but it's still a really common issue in injection drug users. And 25% of HIV-positive persons have hepatitis C, and you saw this data. This says treatment costs range from $83,000 to $130,000 per individual, medications, doctor visits, tests. So I've seen estimates closer to $30,000 to $50,000, and again, the VA and other systems, Medicaid, can negotiate for better costs. Many of you may have seen in the news papers in Florida last week or two that there was some controversy again about whether prisons and people in prison should be more aggressively treated. And from a public health standpoint, it certainly makes sense, but you can also see the price tag is scary to some people. So while these prices are high, I do think slightly this is an overestimate, but the cost of medications themselves still do look to be about $30,000 at least, unless people can find ways to negotiate better treatments. The nice thing about the treatments is it's oral pills, and it works. It can cure in 6 months almost everybody who takes these pills. And those people not only benefit themselves, but they will prevent transmission to other people in the future. And so for every one person you cure, you're also probably preventing transmission to some other person in the future. And I think if we do cure all the people with hepatitis C, it certainly is easy to envision that there would be no more new hepatitis C infections at all in the next decade. So if you really want to know how much hepatitis C infection data we have, you can look at the NHANES survey, which is a national survey run by the CDC every year or two, and they did some hepatitis C antibody testing nationally. There is U.S. Census data where self-report, people report whether they have hepatitis C, and there is a national vital statistics system, and they get information about hepatitis C through some other sources. And so we can look nationally and see how does Florida compare. So if you look at the geographic distribution of absolute numbers of hepatitis C infections in the United States, that means how many, you can see that there are 3 million total in the United States, and Florida had 300,000 of them, so we had about 10% of all the hepatitis C in the United States. So we do have, like other largely populated states, lots of hepatitis C infected people. If you look at the rate, meaning you divide the number of cases by the population, Florida comes up a little bit more average. And I don't know if you remember the map of HIV infection where it really is pocketed in the southeastern part of the country. You can see that hepatitis C is a little bit more in some of these middle American western states and kind of distributed across the country, in some ways related to where there are higher rates of opioid abuse. So people wondered, what makes a community vulnerable to opioid-related HIV and hepatitis C epidemics? And what that means is there are certain communities where you can really expect it's going to be a problem locally. And this was a report that came out, I listed a reference of 2016, and they said that acute, meaning new, hepatitis C infection rates were related to counties that had higher drug overdose deaths, prescription opioid sales, and again we have those data for Florida, per capita income, white race, unemployment, and buprenorphine prescription capacity, meaning that there are more people involved in opioid treatments, which is interesting. So where in the United States do we see combinations of all this stuff? And the reason I show this slide is interesting because Florida's not on it. We really don't have specific hotspots in Florida other than those areas I showed you earlier that really seem to be uniquely vulnerable. And here we see in Appalachia, United States, you know, where some of the deaths are occurring and some of the new transmissions are occurring is right across the central of the country. So it's kind of interesting, but these are pockets of people that had those combinations of more white persons, more opioid in the communities, and more unemployment. And so that's what's happening. So even within Florida, although we didn't make this map on the hotspots, I think you did see that there are certain areas that could be more vulnerable. But just like that county in Indiana, any place could have sort of an urgent outbreak that, you know, could really emerge undetected until, you know, some signal really stands out. So the last thing I was going to do in my talk for the last 5 or 10 minutes is talk about some strategies to reduce hepatitis C and HIV in persons who inject drugs. I'm going to talk a little bit about some strategies specifically in Florida. And again, our colleague, Mr. Bennett, is going to talk in more detail about these strategies. So here's a summary of different types of things to prevent or reduce hepatitis C virus and HIV in persons who inject drugs. And so there's 3 types of interventions. One is antiviral-based interventions. So that can be pre- and post-exposure prophylaxis. So that means that if people are sharing needles of injection drugs and they take pre-exposure prophylaxis for HIV infection, that can reduce their risk of acquiring HIV infection. Post-exposure prophylaxis is a situation where someone didn't mean to share drugs, but for some reason something happened and they know that yesterday, by mistake, they shared needles with someone they shouldn't have, and now they've been exposed. They could take post-exposure prophylaxis, which is just like what happens with a healthcare worker who gets exposed, 2 weeks of some type of antiviral HIV medication. I don't have as much data in injection drug users, but certainly I would get the word out there that if people have been exposed through injection drug use unintended to someone with HIV or someone who could have had HIV, they could receive post-exposure prophylaxis probably by going through their county health department. And this also sets treatment as prevention. And what that means is if we treat people with antiviral medications for HIV and suppress them to undetectable, or if we treat people with hepatitis C and cure them, we can reduce HCV, HIV transmission in persons who inject drugs. So certainly this is one of our main intervention strategies. Risk behavior reduction interventions is another group. These are interventions for injection drugs risk. So those are things like needle exchanges or providing clean cookers or other types of materials that are used to inject drugs, and interventions for sexual risks. And so again, those interventions could be making condoms more readily available, for example, or encouraging people and reminding them about the risk of HIV through sexual transmission. And then finally, substance use treatment and overdose management. So behavioral modifications or psychotherapy to try to help people with injection drugs to stop using injection drugs. Pharmacologic medications, we did talk about buprenorphine, and there's certainly naltrexone. There's some other pharmacological interventions that can be used, because if we can, you could imagine some controversy about getting people off injection drugs and on some type of oral medication like buprenorphine or methadone. But buprenorphine and methadone are not associated with transmission of hepatitis C and HIV, and injection drug use is. So certainly if you're trying to prevent these infections, and 27,000 new hepatitis C infections in Florida, getting people on oral opioids instead of injection opioids will reduce transmission. And then there are naltrexone distribution. So again, naloxone, it's hard to read this, I'm sorry, but that's certainly, we are seeing more and more people distribute naloxone kits to people who might overdose in order to prevent overdose-related deaths, which is independently a horrible thing, but may not independently stop HIV/HCV transmission. But those are basically our 3 strategies: antiviral interventions, risk behavior interventions, and I'll talk a few of those, and then substance abuse treatment. So PrEP, again, for people who aren't familiar with it, it's a new prevention method in which people who do not have HIV infection take a pill daily to reduce their risk of becoming infected. PrEP is available. It is expensive. It's not really covered by insurance, but it is people that don't have money can access it through the drug company with help. It does require a doctor's prescription. We have PrEP programs in a lot of our public health settings in most counties in Florida. And so people who either are, for example, men who have sex with men who intends to use condoms, but sometimes doesn't, they don't have HIV, they could take PrEP. And if you're an injection drug user who is addicted and know that you might slip up and share drugs or become infected, you could use PrEP in this population. Again, part of the barrier, just like the hepatitis C treatment, is cost. And so all of us involved with policy can think about what we can do to influence the cost of these effective interventions, because they're relatively harmless to take PrEP. It just costs a lot. Florida has really worked hard. You've seen the data. It doesn't look good for Florida, but I will give Florida credit. In the last 2 years, we've really started a lot of HIV initiatives to try to reduce HIV transmission that do include some of those tiers of getting people on PrEP, getting people on treatment if they're positive, getting people tested, trying to do behavioral interventions, trying to do what we can to get people on treatment more aggressively. And I think that you can see some HIV prevention interventions overlap with the injection drug use epidemic in terms of needle sharing programs, for example. So I'll mention this, and I know Jesse is as well, but it is an interesting thing happening in Florida because the Syringe Services Program, it says more than just needle exchange. It's a community-based program that ideally provides comprehensive services. So it could give sterile needles and syringes. It could provide people with safe disposals of needles and syringes. People can be referred to mental health services or substance abuse treatment services. You can do HIV testing, hepatitis C testing in this setting. You can provide vaccination against other viral infections. You can discuss things like condom and PrEP to prevent HIV, and certainly overdose treatment and education. We can think about how to help people at a syringe service program avoid overdose treatment and education. So public health is kind of very positive about the potential for HIV injection drug use through syringe services programs for HIV infection. I'm not going to read this whole slide. It does discuss what people can do, but it just reminds us that about 1 in 10 HIV diagnoses are among people who inject drugs. Maybe it's 7%. More than half of people injection drug use used a syringe service program in 2015. Now, that's not necessarily the case in Florida, and only 1 in 4 people with injection drug use got all of their syringes from sterile sources. So it also means that even if you do provide a syringe exchange program, people still could be getting needles from other sources. This is the Miami Injection Drug Exchange Initiative in Florida. I copied this from a Facebook page, and if you're interested in the history of drug exchange programs in Florida, I encourage you to go to Facebook and look up the Miami Exchange, because it really gives the whole history back about 8 years of how they first tried to get the Florida state legislature to pass a law to allow needle exchange. There was no legal needle exchange in Florida until about 2 or 3 years ago, and this program fought for many, many years in a row to try to finally get approval. And I heard a talk from them recently in Miami, and it was really encouraging because they do require people, in order to get clean needles or clean needles, you have to bring in used needles. And so what they found was also some of the injection drug users were even helping to clean the neighborhoods, getting some of the needles picked up, and there were fewer needles in the neighborhoods on the ground. They do give out condoms, so they try to provide HIV prevention education. They give people access to services and things like that, and so far it's worked pretty well, but it does take sort of an, at least they argued, an academic partnership with the community organization. It does take funding because we do need administrators to be sure the program is working properly, to follow the rules. There is a lot of documentation. But so far, this group, which does do hepatitis C testing, does do HIV testing, seems to really be having a very positive impact, and they are very interested, those involved with this exchange in Miami, in helping other communities to figure out a way to suggest or plan a needle exchange in their communities, because those exchange programs will still need to be approved by the state. But I think the fact so far as this one's working very well, They are also looking for funding ideas to extend this. And again, I think you'll hear more about needle exchange later. It was founded in 2016 as a harm reduction program. It does provide clean syringes in exchange for use. They do anonymous HIV/HCV testing. They do linkage to infectious disease and substance abuse treatment services. They do partner with local law enforcement. So if the police find the people have a card that says they are participating in this program, and the police then seem to be leaving the drug users alone for the most part, and then they do provide information to the community about overdose prevention. And again, that is a critical aspect of injection drug use now, is preventing these fatal overdoses. Well, this is the end of my talk. I'm ending with a picture of my research team here in Gainesville. We are the Southern HIV Alcohol Research Consortium. We are interested in lots of things related to anything surrounding HIV and alcohol. So certainly other substances, other HIV-related factors are things we study here in Gainesville, and if you're interested in what we do, you can look at our website here. We are very interested in what's happening with the opioid epidemic and trying to facilitate people who want to do research or evaluation of programs. I'm happy to try to help with that. And I'm going to stop now and let our moderator decide if she wants to take some questions now or move on to the next talk.
Dr. Cook, thank you so much for that. And I do think that we have a question that we can address before the break, fairly straightforward. And I think that it's connected to one of the slides where you were showing statistics around demographics. But simply stated, it's asked, what is the age range of the largest number of HIV patients?
So a lot of the data I've been showing relate to new infections. I didn't show you as much data about all infections. When you look at all infections in Florida, if I had a graph and you could imagine bars of people aged less than 25, maybe 25 to 50 and greater than 50, in Florida right now, 50% of all people, all 110,000 people living with HIV are over age 50. And we expect that in 5 or 6 years, we will have a much higher proportion over age 60. And that's because people with HIV, for the most part, are surviving much longer now with the current therapy. And so we're seeing more and more older people with HIV, and the relative proportion of people with HIV in the younger population is less. On the other hand, if you look at the new infections and where are the new infections coming from, it's almost the opposite, in that the greatest number of new infections, of the 4,800 or so, are in people under age 25 or 30. And so while, you know, there is always discussion about these older persons having a lot of risky sex or, you know, continuing to use drugs, I think our treatment programs really need to consider, you know, how we deal with aging populations, but our prevention programs, while not ignoring them in the older populations, you know, do need to really continue to pay attention to our younger populations.
Thank you, Dr. Cook. At this time, we will take a 5-minute break. And actually, since we're so close to 11 a.m., we'll just go ahead and resume the presentation with Jesse Bennett, and we'll pick up sharp at 11 a.m. Thank you so much. Jesse, are you going to be ready to go in a couple of minutes?
Yes, can you hear me?
I can.
Okay.
Jesse, I just passed the presenter privileges to you, and you should see your presentation on the screen now. And I'll just say welcome back to everyone. It's 11 a.m. We're going to resume today's webinar, and Jesse Bennett's going to get us started.
Okay, can you hear me?
I can, Jesse. Go right ahead.
Okay. So my name is Jesse Bennett. I'm an outreach worker for the North Carolina Harm Reduction Coalition. I'm a former IV drug user and a formerly incarcerated individual as well. I operate a syringe exchange program in Raleigh, North Carolina, and we do lots of North Carolina Harm Reduction Coalition. Does a lot of overdose prevention programming with naloxone access, syringe access, and also engaging with individuals who do sex work. So my presentation is going to cover, information around relationships between opioid misuse and infectious disease, what types of things we can do to effectively address the issues surrounding explosion of hepatitis C, overdose deaths, and then using evidence-based interventions to approach individuals who inject drugs. So harm reduction. So why is there a need for harm reduction? Obviously, responding to disproportionate disease and fatality rates. It reaches vulnerable populations, so populations who have been stigmatized through healthcare and other professional areas, and harm reduction is able to engage with these individuals on a different level. And then keeping individuals engaged if they relapse or they're not abstinent. Harm reduction, what harm reduction does is address harms related to drug use and sex work. So we never expect our participants are going to stop using drugs. We would love that to be an outcome at some point. And as I'll talk about later, we just really want to create any positive change in their lives. So Dr. Cook went over these slides. I don't think I need to do them again. So what good comes out of harm reduction? So we get to challenge stigma. drug users, persons who use drugs, are already stigmatized, and those individuals who inject drugs are not only stigmatized as drug users, but they also face a whole nother set of stigma within drug-using communities by being IV drug users. They also have other health issues, and so stigma is perpetuated through healthcare and pharmacies and things of that nature. Increasing trust with clients and fostering engagement. So the relationship building that comes from syringe exchange programs or engaging with individuals through outreach programs. These relationships are very important to engagement and retention of eliciting any positive change. And so we not only do we get to improve the health of the individuals, but by improving the health of individuals, it also improves health of the community. So harm reduction is a set of practical strategies to reduce negative consequences of drug use and sex work, or even sex risk. And so we incorporate lots of strategies, so safer use, managing use, all the way up to abstinence. And when we talk about managing use, we get into principles like harm reduction-based therapy, which tries to address underlying issues that lead to drug use before addressing the drug use itself. We meet people where they are, but we never leave them there. And it goes, I meet someone where they are at that time in their life, and even when they get into recovery or get on medication and want to disengage with services, still follow up with them, make sure they're doing okay, and really just keep fostering that relationship. Because everyone knows relapse is a part of recovery, and we never want the individual to feel like that if they have a relapse or a return to use, that they can't ever come back and engage in services with us. So we never attempt to minimize or ignore harms associated with licit or illicit drug use. We recognize there are lots of harms associated with it, and not minimizing it, but treating it with best practices is always the best course of action. And so applying evidence-based interventions and reducing negative consequences of these behaviors. And so as Dr. talked about earlier with PrEP, and then with us using syringe access programs to initiate testing or bridging them to linkages to care for treatment of Hep C or HIV, bridging the treatment provider spectrum, and then also naloxone access. So harm reduction moves past judgment of another person to address drug use and sexual activity and the harm that is occurring to that person. So it is a non-judgmental, non-coercive provision of services. And so we work to elicit any positive change. So when I talk about any positive change, individuals who engage in syringe exchange programs are eliciting a positive change, right? They may not be changing their drug use. They may be on all over the continuum of the drug use spectrum, but they've made a big step by coming out of their comfort zone into mine and getting supplies to try to change the outcome of their health. And then all the way up into testing, medication or abstinence services. So what harm reduction is not. It does not mean that anything goes. It doesn't mean we don't condone or endorse or encourage drug use or high-risk behaviors. We simply want to reduce any type of harms related to these behaviors. And recognizing that these behaviors, individuals are going to engage in sex work and high-risk sex behaviors. Individuals are going to use drugs, and everybody should be treated with dignity and worth, regardless of the situation they're in. So harm reduction, we don't ever. There's a lot of times people think we want to force individuals into medication-assisted treatment. What we do is, and I'll discuss this later, is approaching everything from a person-centered approach, and really, through motivational interviewing, engaging with our participants, and finding the best course of action that they want, and really recognizing that a lot of times what I think is the best course of action or best course of intervention for this individual may not be what they think is. So levels of harm reduction include the individual, institutional, and community, and all these kind of work together to reduce harms associated with each one. And they all, as we can see, work side by side. So harm reduction is a holistic approach to working with people that are high risk for HIV, drug use, sex work, sexual behaviors. These programs that we operate need to be low threshold. They need to be convenient, and they really need to be based on evidence or best practices. And convenient being if I'm serving a particular population, obviously I don't want my syringe access program to be as far away from them as possible. I want it to be as close to them as possible. And then providers need to be positive, honest, productive, pragmatic, client-centered, and without bias. And so it's really important for providers to practice cultural humility and understand the world through the drug user's eyes, recognizing your own internal biases and working towards your client's needs through a person-centered, non-judgmental approach. So drug use, this is the continuum of drug use, and it operates along the spectrum. And so an individual could be operating along this spectrum back and forth. You can have a person who is abusing, that has a habit, and then going back to no use, and then maybe they're going back and forth through like social use or binge using. And so we really need to understand just because an individual is the way they use drugs doesn't mean that they're either severely persistent, chemically dependent, or what I like to call chaotically using drugs. And so understanding the individual as they are, and really building those relationships and seeing what's going on in their lives, and we'll get into that in a minute. So the degree of harm associated with risk behavior varies, and it's along the spectrum as well. And so these factors include the drug, the set, and the setting. So the drug, the drug used, how it's used, the pharmacology of it, how much is used, the set will be like the mindset or demographic, mental health, interpersonal skills of the individual, and then the setting, like what's their economic status, what's their emotional status, what's their cultural status. So the key principles of harm reduction are health and dignity, participant-centered, participant-involved, participant self-ruled, and recognizing inequalities and injustices, and it's practical and realistic. So health and dignity. Providers treat participants with respect at all times, and really recognizing that different people are going through different stages. We don't know how they're coping with trauma or adverse childhood experiences, and really not judging how they're going through a situation, and always showing them respect, and understanding that there is no hierarchy in this, and that we are considered equals. And so participant-centered, we offer services without judgment. It's low threshold, and it should be accessible to the individuals. Obviously, I don't, I have a fixed site syringe exchange, and I have a mobile exchange, and for the purposes of there are individuals who can't access the fixed site, but they should still be able to access my program, and so then that's where delivery comes into play. And so participant involvement. So we want to ensure that that the individuals we're serving have a real voice in the creation of programs and policies. So North Carolina harm reduction, obviously, so we hire and employ former and current drug users. And before we bring policies to legislation, we have surveys that we put out to each of our programs, and we really want to understand what is important to the individuals we're serving, because once again, sometimes we think certain policies should be passed, but at the time, participants don't think that, and they really should have a voice in these programs that we're creating for them. So participant self-rule, we need to recognize that these individuals are experts in their own lives. It's the participant who makes their own changes, and this is when they feel they can make them under their own circumstances. So this is great, arena for using motivational interview and strength-based perspectives, and encouraging any type of change, right? So going through the whole of engaging in syringe exchange program, using one needle at a time, using alcohol swabs, and things like that, and really supporting those changes, and encouraging them to continue with positive change. So we also need to recognize the complexities of poverty, class, racism, isolation, trauma, adverse childhood experiences, sex discrimination, and so these underlying issues creates vulnerability and in the capacity for effectively dealing with behavior-related harm. So a lot of times we want to start addressing these underlying issues before addressing drug use. For most of us, drugs are a solution to all our problems, and until we address the problems, we don't want to take that away. Individuals are really in these comfortable areas of using, and sometimes it's the simple things such as food, shelter, and clothing, and trying to get individuals to the next step. So we offer practical tools and education. Yes, we supply syringes. Yes, we do testing. Yes, we provide naloxone. But on top of that, we have groups or classes specifically to teaching individuals who are using drugs, you know, how to prevent HIV and hepatitis C. And we have groups specific to women or women who have children, because there's a lot of other issues that surround that, and they need an outlet to come talk about these issues, even though they're using drugs. So drug use. So what are some common risk factors surrounding drug use? Abscesses, obviously, HIV and hepatitis C. What we're seeing a big increase, explosion of here in North Carolina, especially surrounding IV drug use, is endocarditis. And what that is bacteria that gets on the heart valves and creates a lot of issues with heart problems. And then obviously one of the biggest risk factors surrounding drug use is death. So people have different reasons for using substances, and we need to consider these factors, the factors surrounding these behaviors when we're brainstorming options to reduce risk for disease transmission, and as well as developing interventions surrounding these. So we'll go into the drug set and setting again. So factors related to drug use, the drug. What type it is it a liquid? Are they injecting pills, or are they taking pills orally? Is it powdery substance, or is it a gooey tar substance? The potency of the drug, and then what the drug is cut or mixed with. I think as I was watching the last presentation, you guys are seeing an uptick of fentanyl. We most definitely are. And so not only are we providing naloxone to individuals, but we also provide fentanyl test strips as another avenue for individuals to test their drugs, to understand that there is fentanyl in it, and then make decisions regarding how they want to use that drug. So factors related to drug use, so the set. So when an individual is in withdrawal, it changes the circumstances, right? So individuals aren't using best practices. You know, they're really trying to feel well. They might use in a public place. They might be reusing syringes and not, you know, practicing what they normally practice. But then when an individual is not in withdrawal, they can still take care of business, right? They still can provide themselves with food a lot of times. You know, everyone still has their cell phones, and they're able to set aside money for drugs, and then cultivating more than one dealer. So the setting, so unstable housing or homelessness, so using in public places. Access to clean water is a big one, especially for our homeless population. We provide sterile water in an effort to reduce individuals from getting water from places like creeks or streams or puddles, things like that. And then using used needles, you know, only situations depending on law enforcement practices, why individuals will only have one syringe, things like that. Yes, and nowhere to put sterile gear as well. So the setting, so using alone, so no overdose response occurs, right? So a lot of times people will use alone when they're having a return to use. And so it's really important to reinforce that having a return to use is okay. And if you do have that, then reach out to someone and make sure you're not using alone. Obviously, individuals who are leaving treatment or in incarceration or have been separated from their drug of choice for a long period of time are at higher risk for overdose death. And then injecting by another person is really dangerous because you don't know how much is used, and then you're also having to use with this individual all the time. So harm reduction options surrounding drug use. So for us, it's not only important, but we think it's irresponsible to operate a syringe exchange program and also not offer offer smoking utensils. So if I'm not encouraging my participants to reduce harm by putting needles in their arms, by not offering them another form of way to use their drugs, then I'm not really practicing real harm reduction around that. You know, smoking drug or swallowing it not only in pill form but putting it in other places in your body reduces harms around injecting. And then providing individuals with snorting devices. Hepatitis C lives outside of the body for a long period of time. Pipes can, they get hot. People get cracked lips and bleed. The straw can get blood from nose bleed type situations. And you can pass these types of hepatitis C onto individuals through these types of use. So obviously, in a perfect world, we want our participants to clean the skin before injecting with alcohol, using a new syringe for each injection, and then preventing fatal overdose with rescue breathing, calling 911. We have a good Samaritan law here, and we really reiterate the fact that of the protections around that, and having individuals call 911 and using naloxone. And so when we provide our participants with biohazards and alcohol pads and as many syringes as they need, we do see the decrease of reusing syringes and people and being able to empower individuals to take control of their own health. They start using the alcohol pads, they start using one syringe at a time and using biohazards and eliciting positive change. So best practices to assist individuals in managing substance use through harm reduction, education, and interventions. So we educate individuals to manage their substance use. So, if they don't have fentanyl test strips, to use a small amount at first just to determine if it's too strong or it's just enough or not enough. We also, instruct them to inject slower. And obviously these types of practice change through the set and the setting. So we educate individuals to manage substance use to have a plan. Letting other people know where to find naloxone. You might have roommates that don't use drugs the way you do, and you really always want people to know where naloxone is because anybody can use it. And then really reinforcing and reiterating the fact of not using alone or letting someone when you use. Overdose deaths are one of the most preventable deaths there is, especially with access to lots of naloxone. And then really trying to encourage your participants to clean their hands or fingers before preparing their drugs. So if they're IV drug users, we really want them to use a sterile syringe every time. But if they're not going to, we want them to only reuse their own syringe. And if at the very worst case scenario that they do need to use somebody else's syringe, then this is what would be acceptable would be a water wash, and then a bleach wash, and then a water wash. Educating our IV drug users to clean skin with soap or water, or clean fingertips, especially using the alcohol wipes. And then, so we provide cottons, cookers, tourniquets, syringes, and the reason we provide all these things, of all these supplies, is it gives us the opportunity to educate individuals on hepatitis C, how long it lives outside the body, and typically most hepatitis C transmissions aren't syringe to syringe, but individuals sharing work, sharing cottons, sharing the same cooking supplies, and things like that. And then educating them on safer areas to inject, or teaching them to rotate. Rotating from different parts of the body will decrease abscesses, and then disposing of used syringes by providing biohazards, so they can return the biohazards. So this is kind of our roots in action. It kind of keeping people alive, and this is Dave Purchase. So Dave's no longer with us. Dave is the founder of the North American Syringe Exchange Network, or NASN, and Dave has moved on from this world, and actually one of his ex-wives, Sue Purchase, works with us now. But Dave is one of the founding pioneers of syringe exchange programs, syringe access programs, and then developing a network through NASN of all syringe exchange programs, and then supplying those programs as well, and giving new programs an upstart, and helping them get going with free supplies. So syringe exchange or syringe access is a science-based intervention that does not increase drug use. It does reduce HIV and the risk for Hep C, and it increases the likelihood for program participants to seek treatment. Individuals who access are 5 times more likely to access treatment through syringe exchange programs, and those that access treatment through these types of programs actually have higher retention rates than those that do not. So HIV and drug use, and so we see that 1 in 10 HIV diagnoses are with people who inject drugs, and then more than half of these individuals, more than half of individuals who inject drugs used a syringe exchange program in 2015, which is really neat number. And then 1 in 4 of individuals who inject drugs got all of their syringes from sterile sources in 2015. So we do see an increase of individuals accessing syringe exchange programs and taking control of their health. So what are some types of syringe access models? So our organization actually operates 3 of these 4. So we have a storefront, or what we would call a fixed site model. We have street-based mobile outreach through our vehicles, our vans. And then we have secondary or peer exchange. So peer exchange is super important to the success of syringe exchange programs. The first being because everybody's not going to access a syringe exchange program at first, especially, so for us, we're only been legal since July of last year, so about a year and a half now. And, you know, we would run into situations where people would come in with their whole groups of syringes, and, you know, they would send one person in. So peer exchanging is important because it not only gets more dirties off the street, it also breaks down barriers by allowing individuals who may not be comfortable coming to a fixed site to still access those services. And then it empowers individuals to help out their peer group and really start practicing harm reduction on a different level. And then there are pharmacy type syringe access programs. We do not have any in North Carolina. So sexual behavior. So what are risks surrounding sexual activity? And so risks, you know, a lot of the same risks: STDs, HIV. So factors related to sexual activity. So the sex. What type of sex? Is it manual or hand use? Is it oral? Is it vaginal or anal? And then the set. If a person who injects or uses drugs too, where are they on the drug use continuum? So we know that individuals who are on problematic or chaotic drug use all the way on the one end of the spectrum are probably going to lack safe sex practices. And so this is where testing is important in getting individuals using PrEP or trying to get them, you know, having classes to get individuals to understand why using condoms are important. So if an individual is engaged in sex work, obviously they're going to have multiple partners with a higher rate of frequency. And so obviously they can't conduct an in-depth risk assessment with each sexual partner. And this is definitely a really stigmatized and vulnerable population. So the setting, once again, the unstable housing or homelessness, so less likely to have storage to carry safe sex supplies. So providing some type of way for them to carry it in small Ziploc baggies, things like that. And then hygiene, so, you know, providing, identifying individuals who perform sex work and providing them with sanitizing hand wipes, toothbrushes, and toothpaste, things like that. And then the setting also comes in with low or no income, so individuals will make decisions based on survival or immediate needs. So, so harm reduction options with sex activity, using hands obviously is safer than giving oral or penetration. Using some type of lubrication and lots of it, if there is no condom, will help reduce the risk of chafing or skin breakage, which increases risk of disease transmission. And then avoiding oral sex with cold sores and stopping the spread of herpes. So in best practices for individuals to manage their sexual activity, so carry condoms and pocket lube, using the silent alarm. A lot of our, not a lot, but a few of our sex workers have partners that also, especially homeless population, the woman will do sex work, the man will panhandle, and so we always want the female to let her partner know like where she's going. Each one can have contact with each other, and if there is separation, that they still continue to contact each other or check in when they return from their activities. Getting tested regularly and bringing own safe sex supplies. So we do, with mobile outreach, we do a lot of rapid testing and the HIV swab, and then finger prick for the HCV, and then if they are positive, getting them linkages to care. So more best practices for sex activity. A lot of diseases have cures, so getting tested regularly, asking for cultural throat culture and anal swabs, completing their Hep A and B vaccination series, and really getting connected with your health department to come provide these services at your fixed site, or even doing their own outreach with you. Obviously getting tested for HIV and Hep C, carrying handy wipes or alcohol wipes, using mouthwash or brushing their teeth between encounters, and then being familiar with menstrual cycle and understanding that blood is blood, and diseases can be transmitted through this type of transmission. So prevention during sexual activity, so condoms, gloves, finger cots, which are kind of like condoms for the finger, to prevent HIV, STIs, viral hepatitis, and unwanted pregnancy. Seeing if individuals are candidates for PrEP, and really trying to prevent the spread of HIV with high-risk populations. So all of these can increase the risk for harm. So unstable housing, obviously low or no income, feelings of isolation, not having access to these supplies and not able to use the supplies you have access to. So these are the 6 psychosocial functionings of individuals, and these are the contributing factors and harms to each one of these functions of life. So we can see the physical function of having poor health outcomes or being exposed to violence or lots of overdoses, depression, stigma, isolation, the social bonds being broken, relationships issues, and then isolation, developing a lack of community or isolation from your own community. And then loss of housing, discrimination, arrest, incarceration. So harm reduction strategies. So because harm reduction interventions and policies are designed to reflect specific individual and community needs, there is no universal definition or formula for implementing it. Each community has different needs, and each individual we have to provide for the participants we serve, and they all, my participants in Raleigh might have different needs than participants in Charlotte or Durham or Wilmington. So it's important to have education, access, support, and linkages. And this is how we reduce drug-related and sex-related risk behaviors. So examples for education, HIV, STD prevention, not only through pamphlets, but classes as well, having an overdose response, and hepatitis C treatment. Access, examples for access would be housing assistance, syringe access, safer supplies. And then examples for support is active listening, case management, and motivational interviewing. And then the examples for linkages would be linking individuals to care for hepatitis C or HIV, drug and alcohol treatment, and then mental health providers as well. So true or false, we can see it says false. Harm reduction excludes abstinence as an option to reduce harms. We absolutely do not, and we include this slide a lot because a lot of times people think harm reduction is, we don't agree with abstinence-based programs. This is not the case, and we completely support whatever pathway the individual chooses to be their recovery, and it's important for the individual to own their own recovery. And if we're not doing it from a person-centered approach, then they are not owning it. Harm reduction offers options so the person themselves can determine what is right for them at the time. And this is true. So what works for one person may be very different from the next. And so we provide a bowl of options which person can pull from them and utilize when the circumstances allow. So reflective practice applied. So identifying areas where you may need more support in applying specific harm reduction interventions at work, and then describing what harm reduction is to your colleagues, and your definition may change over time, and then applying. So does asking these questions? Does your agency engage in key principles of harm reduction? And then how can you integrate this harm reduction approach into daily work with clients? Even if you're not providing them syringes, how can you, as a provider, decrease harm in your clients' or participants' lives daily? And that's all I have.
Thank you very much, Jesse. We appreciate that. And at this time, we don't have any questions, so we're going to go ahead and proceed. At this time, let me double check the questions one more time before I say that. No, I think we're good. We just have a couple of people who want to extend a thank you to you, Jesse, as well.
Cool. Thank you, everybody, for listening to me.
Yeah, of course, of course. So, of course, we do want to specifically thank Dr. Cook as well as you, Jesse, for taking time out of your schedule and speaking with us today and sharing your expertise and your personal experience as well. We very much appreciate it. And I do want to remind all of the participants. Oh, and Jesse, by the way, I am taking control back of the presentation, if that's all right.
That's fine.
I do want to remind everyone that when we exit the webinar, you're going to be directed to an evaluation form, so please do complete that evaluation, and that will allow us to go ahead and do what we need to do, and in terms of the certificates of attendance and reporting as we need to. And then finally, I do, of course, want to specifically thank the Florida Department of Children and Families. the Office of Substance Abuse. We appreciate them for funding today's presentation. And thanks to all the participants who joined us today. We appreciate your interest in our program as usual. So again, Dr. Cook and Jesse Bennett, thank you so much. We appreciate it.
Thanks for having me.
Bye-bye all.